Friends, good morning everybody. Welcome to the second day session.
Hello.
First session is title on cataract surgeries. So it's a free paper session on cataract surgeries. I'm sure the participants would have put in a lot of effort and they will be enthusiastic to share their research findings. All of you know the rules of the game. It's 5 minutes per presenter and you have to stick to your time. You will be judged on 4 parameters. The content, how you present, slides and the originality. Okay, so be cool, calm and stick to the time. If you are ready, we can start your timer now.
Yes, sir.
So I welcome Dr. Manupriya. Dr. Manupriya, yeah, you can start. AV team वाले presentation load करना और इधर भी on करना, ये भी on करना.
Next in line is Dr. Divya Kumari, but
Dr. Shilpi.
Dr. Shilpi, yeah, because at that time she wasn't there.
Okay.
She has another presentation in another hall apparently. Have you loaded your presentation? Yeah, okay. She can present then, she is in line.
Okay, so I'll go.
Yeah. After her, Dr. Divya Kumari will present.
Good morning, everyone. I am presenting my paper titled Outcome of Cataract Surgery in Patients with Coexisting Ocular Pathologies that Cause Technically Difficult Surgery. There was no financial support or sponsorship, and there were no conflicts of interest. Cataract is responsible for around 50% of all blindness globally, more than 90% of which is found in low and middle income countries. Despite millions of cataract surgeries done each year, cataract still remains a major cause of blindness all over the world. According to WHO, there is a 25% decrease in blindness prevalence in India, which may be attributed to the increased rate of cataract surgeries in the country. At the same time, the proportion of the aged has also increased significantly in the country, which means the population at risk of blinding cataract has also increased. With increasing age, associated systemic and ocular comorbidities may also increase. The World Health Organization recommends that poor visual acuity, that is less than 6/60, or borderline visual acuity less than 6/18 to 6/60 following cataract surgery should not exceed more than 5% each after best available correction. Cataract surgeries in the presence of comorbidities does not always result in optimal outcome and are associated with many technical difficulties during surgery. Learning to recognize eyes which are at greater risk and acting accordingly helps to prevent or minimize complications. Along with that, such patients may be counseled preoperatively about possibility of poor outcome. This helps in improving postoperative compliance and follow-up. Knowing about ocular comorbidities also helps in better planning the surgery and anticipating any likely complications and preparing for the same. The aim of the study was to study the complications of cataract surgery in eyes with coexisting ocular pathologies and their outcome. After obtaining approval and clearance from Institutional Ethical Committee, a case-control hospital-based study was done in the Department of Ophthalmology, Sri Ramamurthy Smarak Institute of Medical Sciences, Bareilly, Uttar Pradesh, to study the complications associated with cataract surgery in eyes with coexisting ocular pathologies and their outcome. Patients who were above 40 years old presenting to the OPD with cataract and existing ocular comorbidities were included in the study. The exclusion criteria were any retinal pathology, glaucoma, intraocular foreign body, microphthalmos, nystagmus, squint, corneal or scleral tear. 100 patients fulfilling the criteria were included in the study, and 100 age and sex-matched controls were taken. Demographic details including age, sex, socioeconomic status, etc. were recorded. Detailed history was taken. Any associated systemic conditions were noted. All patients underwent complete examination, preoperative visual acuity, tonometry, slit lamp, biometry, and fundus examination. Associated ocular comorbidities were identified and noted, including corneal opacity, any degeneration dystrophy, posterior polar cataract, senile meiosis, pseudoexfoliation syndrome, uveitis, zonular dehiscence, complicated cataract, and so on. All patients were planned for phacoemulsification surgery with IL implantation under local or topical anesthesia. One clear corneal incision and 2 side ports were made. Continuous curvilinear capsular access was done using cystitome, followed by hydrodissection and phacoaspiration of the lens matter. PCIL was implanted following this, and the wounds hydrated. Any intraoperative complications like zonular dehiscence, iridodialysis, vitreous loss, posterior capsular rent, ACIL implantation, aphakia, and conversion of phaco to small incision cataract surgery was noted. Patients were examined post-operatively on day 1 for early post-operative complications, and visual acuity was recorded. Now, according to the WHO, the classification of visual acuity for cataract surgery outcome that was used in the study, good outcome was BCVA better than 6/18, borderline was BCVA between 6/18 to 6/60, and poor outcome was BCVA less than 6/60. Coming to results, a total of 100 eyes of 100 cases with cataract and ocular comorbidities who underwent phacoemulsification surgery were analyzed. Of the 100 cases, 56 were males and 44 females, and the mean age at surgery was 61 plus minus 11.73 years. Now, the most common presenting ocular pathology was corneal opacity in 31 patients, followed by posterior polar cataract in 25, uveitis in 19%, pseudoexfoliation syndrome, zonular dehiscence, senile meiosis, coloboma, and complicated cataract. The common intraocular complications encountered were conversion of phaco to SICS in 18 patients, vitreous loss in 15% patients, posterior capsular rent, iridodialysis, implantation of ACIL, aphakia, and there were no complications found in 28 patients. In the case group, as we can see in the graph, the intraocular complications in the control group is much lesser compared to the case group, and the p-value is significant, that is less than 0.05 for each of these. Now, coming to the post-operative visual acuity, it was better in the control group. In 88 patients in the control group, the visual acuity was better than 6/12 as compared to 44 patients in the case group. And again, the p-value here is significant. It is less than 0.0001. Now, coming to discussion, cataract is the leading cause of blindness worldwide, and in India, the numbers are increasing due to a substantial increase in population over 50 years in the last decade. Although upgradation of technology, type of machines, types of lenses, and surgical expertise, the number of cataract surgeries has substantially gone up along with better results. However, coexisting ocular comorbidities may cause intraoperative and post-operative complications with poor visual outcome. Our aim was to study the outcome of cataract surgery in patients with coexisting ocular comorbidities that cause technically difficult surgery. In our study, it was evident that presence of comorbidities increased the complication rate. The most common presenting comorbidity was corneal opacity. Most common intraocular complication was found to be conversion to SICS, followed by vitreous loss and PCR. Post-operatively, only 44% patients had vision better than 6/12. In a study done in Liberia in 2019, total 573 eyes were included, out of which 82 had ocular comorbidities. 23% patients had posterior capsular rupture, and 21.9% patients had zonular dehiscence, which is comparable to our study.
No, you need to wind up. Your time is over.
And our study is also comparable to a study done in Nepal, where good, borderline, and poor visual outcome were found to be 41%, 45%, and 13% respectively. Conclusion, this study shows that rate of intraoperative complications is higher in patients with pre-existing ocular pathologies. Detailed preoperative evaluation and identifying any pre-existing ocular pathologies is crucial before cataract surgery. This could help in improving outcome by optimizing patient selection and surgical approach. The limitations of the study was that it was a single center study and the sample size was small. Thank you.
Thank you, Dr. Manu. And I request all the speakers to stick to your time, because you will be rated based on your time also. So otherwise you will lose the marks. Okay. So one question, what's one limitation that you have in this study apart from the two that you have mentioned? Or what is new in your study?
Sorry, sir.
What is new in the study?
Sir, we are trying to find out, like we are emphasizing the pre-operative workup that should be done and counseling of the patients so that we can better handle the surgical approach of the patient and also better counsel the patient. So that post-operatively, even if the visual outcome is poor, then the patient will not be very dissatisfied.
Thank you, thank you. Paucity of time, otherwise we could have asked more questions. Yeah.
Why did you limit the age to 40? Any specific reason?
So like we did the study in adult age group only, like less than 40 years. There may be other reasons for cataract like trauma or diabetes mellitus or something that we have not considered in this study. So they are also a cause of poor outcome.
Maybe your sample size was small. When
Yes,
you
sir.
increase sample size to 10,000, 5,000, then
Yes,
you can
sir.
include that. Thank you. Thank you.
Thank you, sir.
Yeah. Next presenter is Divya Kumari. Huh? Okay.
Thank you, sir. Myself, Dr. Divya Kumari, consultant Sharpsight Center, Patna. My topic is outcomes of heparin surface modified versus non-heparin surface modified IOLs in diabetics after phacoemulsification. No financial interest. Patients with diabetes mellitus develop cataract at an early age in normal population. There is disruption of blood aqueous barrier even without clinically visible diabetic retinopathy. The phacoemulsification technique has improved significantly. Still, it induces trauma leading to blood aqueous barrier breakdown. Blood aqueous barrier breakdown can be measured by a machine called COVA FM600. And also this breakdown can be reduced by decreasing the duration of surgery, mechanical trauma to uvea, decreasing phacoemulsification surgery, decreasing the size of incision, and choosing clear corneal incision, and increasing the biocompatibility of IOL. Our studies centered on the improving biocompatibility of IOL. It compares clinical outcome of heparin surface modified hydrophobic acrylic foldable intraocular lens undergoing phacoemulsification in diabetic patients. Laser cell flare meter is most accurate and sensitive method to measure both clinical as well as subclinical AC flare. The two intraocular lenses were hydrophobic acrylic monofocal aspheric. One was IQ and other was CT Lucia 601 PY. The difference being 0 degree haptic angulation in Acris of IQ group and 5 degree angulation in CT Lucia. Study design was a single center randomized control trial with sample size of 100. Primary outcome measures were aqueous flare, central macular thickness. Secondary outcome measures were intraocular pressure, visual acuity, AC depth, and endothelial cell count. Inclusion criteria were age-related cataract in diabetic patients with age more than 45 years and patient willing to give consent and ready for the follow-up. Exclusion criteria were any other ocular disease which might hamper visual acuity. Statistical analysis was done with SPSS 23. The demographic and laboratory parameters were comparable between the two groups. The difference of preoperative axial and corneal refraction implanted intraocular lens power between the two groups were not statistically significant. The mean aqueous flare of posterior polar cataract was found to be the least and hypermature senile cataract was found to be the highest. The two groups were comparable in their distribution of cataract. The preoperative aqueous flare values in operated eye were significantly higher in Acris of IQ group. Intraoperative parameters like ultrasound time, total fluid aspirated, cumulative dissipated energy, and total duration of surgery were comparable. The mean UDVA and CDVA was significantly better in CT Lucia group on day 1 only. 58.5% of cases in CT Lucia group and 41.5% cases in Acris of IQ group achieved a CDVA of 20/30 or better on day 1. However, there was no statistically significant difference in any visual outcome parameters between the two groups at any other point of time. There was no significant difference between the two groups in post-operative central macular thickness during any follow-up. IOP was comparable between the two groups. The mean endothelial cell count on post-operative day 1, the endothelial cell loss was 6.6% in Acrisoft IO group and 8.01% in CT Lucia group. At 1 year, it was 21.66 in Acrisoft IOL group and 19.52% in CT Lucia group. At the end of 1 year, CT Lucia group had better endothelial cell count. The difference was not statistically significant. No significant difference was observed between the two groups on CMT during any follow-up. Both the groups developed 1 case each of clinically significant macular edema. Acris of IQ group had 10 and CT Lucia group had 9 cases of macular edema on OCT without deterioration of visual acuity. CMT was found to be positively associated with fasting blood sugar with beta of 0.21 and a p-value of 0.07, keeping other factors like cumulative dissipated energy, axial length, duration of diabetes mellitus, hypertension, HbA1c, urine albumin, and age of the patient constant. The mean spherical refractive equivalence in Acris of IQ group was minus 0.367 and CT Lucia was minus 0.23. These are the post-operative pictures. The previous study done by Ursel et al. Has found aqueous flare value to increase with increase in degree of nuclear opacity. However, our study could not find any relation between degree of nuclear opacity and AC flare. However, HMSC group had higher AC flare compared to the rest. This probably was because HMSC are higher than normal lens, has more diameter than normal lenses, and it causes increased rubbing of cataractous lens against iris pigments. We also noted ACIOL had higher aqueous flare values than PCIOL in bag. This might be due to the same reason. Urine albumin correlated significantly with pre-operative aqueous flare in both the eyes. This might be because albuminuria heralds onset of systemic vasculopathy and is a powerful predictor of major cardiovascular events and might be associated with blood aqueous barrier disruption as well. Our study found significant correlation
Doctor,
between
please wind up.
preoperative as well as post-operative values. In our study, we found that flare values were not necessarily highest on the first post-operative day. Smaller incision sizes are related to lower value of aqueous flare. Our study could not find any correlation between aqueous flare and CMT at any point of time. This may be due to several reasons like IOL, eye drop nepafinac 0.1% was added. Conclusion, HSM-IOL were superior to conventional hydrophobic IOLs in diabetic patients with respect to anterior segment flare and endothelial cell count. However, no significant difference was found between the two IOLs in terms of CMT and IOP. Recommendation is heparin surface modified IOLs may be implanted in diabetic patients undergoing phacoemulsification, but long-term follow-up is required. Thank you.
Very nice presentation.
Thank you, sir.
Heparin surface modified lenses are the latest arrival in IOL implants. Now tell me one thing, how long did you follow your patients?
For 1 year, sir.
For 1 year. And what gadget you use to count the specular microscopy or just slit lamp examination? And
We counted specular microscopy, sir.
So did you mention it over here?
I couldn't, but we counted specular, endothelial cell count was counted by Topcon specular microscope.
Okay. And in all research work, they have said something about giant cell count, etc. Did you have?
We saw, sir, due to lack of time, I didn't add it, but we saw giant cells also, and it was not significant, difference was not found. That's why I didn't mention.
Okay.
Nice presentation.
Thank you, ma'am.
Yeah, we'll call upon the next speaker, Dr. Shilpi Arya. Dr. Srini, can you please load your next presentation?
A very good morning to one and all. Today I am going to present free paper on the topic Steep Axis Clear Corneal Incision Guided by Phone App Decreases Post-Operative Corneal Astigmatism. The reform of cataract surgery from vision restoration to refractive surgery is widely accepted, and because refractive surgery offers more precise surgical design and faster restoration of functional vision. There have been many methods of correcting astigmatism, which include arcuate keratotomy, limbal relaxation incisions, clear corneal incisions, and toric IOL implantations. But clear corneal incision is less complex and requires less computation than toric IOLs. We also know that postural changes such as transition from an upright position to a supine position may produce a mean cyclotorsional effect of 0.4 to 4.2 degrees. And this effect may be cyclotorsional or excyclotorsional. In this study, however, the keratometry is usually recorded with the patient upright, whereas the eye surgery is performed with the patient supine. We have tried to minimize this effect using the app, that is iToric Patwardhan app, which has an inbuilt gyroscope which works with conjunction of the camera. The methods, material and methods. The aim of the study was to assess residual astigmatism in patients undergoing phacoemulsification with steep axis incision determined by Android mobile-based app. The objective was to assess change in corneal astigmatism at 1 month after surgery. The study was conducted in a tertiary care center in northern India. The duration was 1 year and the study type was prospective observational study. The sample size calculated by Charan Biswas formula was 81 patients, And the patients were recruited according to the inclusion criteria, which included astigmatism up to 1.5 diopters, clear cornea, age between 18 to 70 years, and cataract suitable for phacoemulsification. Patients with corneal disorders and previous ocular surgery in the same eye were excluded. Written informed consent from the patients was taken, and proper history and visual acuity was recorded. Best corrected visual acuity slit examination was done. The keratometry was done on IOL master. A pre-operative corneal marking of the 0 to 180 degree of the steep axis was done on iToric Patwardhan app, while patient was sitting in an upright position. The app gives corrected steep axis and a landmark is identified near to it. The corrected steep axis was then marked pre-operatively while the patient is lying on table using toric marker, and a clear corneal incision was given on the same. The surgical procedure was the patient was operated under topical anesthesia. The surgery was phacoemulsification. Axis was identified on table. Post-operative evaluation, both unaided and best corrected visual acuity was checked on logmar charts, and keratometry was done on IOL master at 1 month post-operatively. A total of 32 males and 36 females were there. The age distribution, this pie chart shows the age distribution. The pre-operative versus post-operative best corrected visual acuity was significant. The steep axis pre-operative versus post-operative was significant, and there was a reduction in post-operative astigmatism. We went ahead and applied vector analysis to our post-operative findings. These charts were given by the astigmative software. The first table shows the target-induced astigmatism, which shows the range of astigmatism that the surgery intended to induce. The second graph shows the surgically induced astigmatism, which is the achieved range of astigmatism. And the third shows the difference vector, which shows the remaining astigmatism and provides a summary of the astigmatic error considering both magnitude and axis. The difference factor is an absolute measure of success. Our study had a difference vector of 0.6, and the correction index shows the under correction versus over correction of astigmatism treatment. It can also be used as a measure of success. An optimal outcome is equal to 1, while in our study the optimal outcome was 1.1. Discussion. Dooley et al. Conducted a similar study with the control group, and both arithmetic values and vector analysis were statistically insignificant in their study. Jinshyati and Marek et al. Also conducted a study in which they showed that temporal clear corneal incision was found to be better than super clear corneal incision. Conclusion. There was a decrease in the arithmetic corneal astigmatism in patients undergoing phacoemulsification with steep axis incision, which was corrected for ocular cyclotorsion using mobile phone based Android app, that is correction for ocular cyclotorsion. The app is highly useful and adds to the value of surgery without causing any economical burden to the surgeon or patient. Thank you.
Yeah, that was a nice presentation. What was different, because this app has also been checked out earlier. So what was the difference between your study and the earlier studies?
Ma'am, we can use this app to reduce the burden. As we all know, Varian is very costly for the surgeon as well as for the patient. And if used, obviously the surgeon will charge for it. This app comes free of cost and also adds value to the surgery in decreasing astigmatism. And it's very useful.
So that is
Very
already
easy
known,
to
right?
use.
Yes, yes. So any specific finding you got? Anything that was new?
In previous studies, there was a difference between right eye and left eye. We didn't find any difference in right eye versus left eye, and there was no correlation with the axial length also.
Okay, thank you. That was a nice presentation.
Shilpi, when you go to study, would you went on to study whether the app is working fine or it suits for the surgery, or what was the aim of the study?
So the
Message.
usefulness of the app and whether it works or whether this.
See, if it is giving the right axis 90 as 90, that is one aspect of that. You were trying to prove that it is showing the right axis, or you were trying to say that it can be used?
So it can be used.
That's known, no? No, when you people go to study, what is the question at hand for which you are...
So that
Compare it with the Varion and you found that this was more accurate or less accurate. That was
more accurate.
that would have been...
been probably something compared to, comparison between two things, technologies, and then you compare and say one is better or the other.
Ma'am, none of
Just a thought, maybe for way forward.
Yeah, good, thank you, thank you. So, yeah, Srini is the next presenter. So Srini, if you are ready, we can start. Go
Mic
ahead,
is
thank you.
on. Thank you, sir. Respected judges and friends, good morning. Our study presents a fail-safe technique for management of posterior polar cataract. No financial interest to declare. When we search the literature, you can see that the PCR rate, posterior capsular rent rate during cataract surgery in posterior polar cataract varies between 7.1 to 36%, and a number of surgical techniques have been described for improving the surgical outcomes and reducing the rate of complications during surgery in posterior polar cataract. We did the study to evaluate the safety and efficacy of phacoemulsification without any hydro procedures for the management of PPC. It was a single center study conducted on 81 consecutive cases of posterior polar cataract that underwent phacoemulsification. And the postoperative data included record of any intraoperative complications and the corrected visual acuity at 3 weeks and 3 months. Sorry about that. In all cases, it was a temporal clear corneal approach. No hydrodelineation was done, and no mechanical dissection was done. So soon after the capsular excess, phaco was initiated. In cases in which chopping could be done, direct chop was done, and once that was initiated, the nucleus was actually rotated, and the nuclear material and rest was fed into the phaco tip. Here you can see the posterior polar element getting into the phaco tip along with the epinuclear plate, and at no point during the surgery, the intracapsular pressure was allowed to fluctuate. So, and you can see the pseudo hole at the end of the surgery. This is a very soft cataract, and immediately after rhexis, the phaco was initiated. This is a very soft cataract, and in such cases, the chopping can't be done. And here the chip and flip technique was employed, and here again, the nucleus was rotated and fed into the phaco tip. And here you can see most of the posterior polar element getting into the phaco tip, and you have a bit of the posterior polar element stuck to the PC. It is very dangerous to polish vigorously here because you'll definitely get a PC rent here. Just peel it off, and whatever remains. And so this is another case of posterior polar cataract with the pre-existing posterior capsular rent, CPCD, the congenital posterior capsular dehiscence. Here again, it is a very soft cataract. Direct chop could not be done, and it is again a chip and flip technique. Again, you can see the nucleus being rotated into the phaco tip, and the whole posterior polar element coming into the phaco tip along with the epinuclear material. And again, it was made sure that the sudden variations in the intracapsular pressure was avoided. And so that's the end of the surgery. And so in none of our cases, we resulted in posterior capsular rent. Two cases had CPCD in which there was neither enlargement of the defect or no vitreous disturbance following phacoemulsification. Two cases developed PCR, that was during corneal wound hydration. However, the intraocular lens remained stable and well-centered. The mean postoperative logmar CDVA improved from 0.6 to 0.04 at 3 weeks, and it remained same till 3 months. So hydrodelineation and other dissection procedures are done during phaco to facilitate the manipulation of nucleus during phaco. It is a rise in intracapsular pressure during these procedures that causes the rupture of an already weak posterior capsule, and this has
Can you repeat this slide again?
Hydrodelineation and other dissection procedures are done during phaco to facilitate manipulation of nucleus during phaco. It is a rise in intracapsular pressure during these procedures that causes the rupture of already weak posterior capsule, and this has to be avoided to safeguard the posterior capsule. In 2 cases in which PCR developed in that study, it was because the anterior chamber was tightened too much and caused increase in intracapsular pressure. In a study, no hydro or mechanical cleaving was done, eliminating the possibility of intracapsular pressure rise. Masuda et al. Showed that mechanical rotation is quite effective in mobilizing nucleus for emulsification in normal cataract cases. Our technique also used mechanical force to mobilize the nucleus, though unlike Masuda et al., our technique, the nucleus rotation was performed after the emulsification was initiated. So to conclude, phacoemulsification without any lenticular cleaving procedures, including hydrodelineation, is a very safe procedure for managing posterior polar cataract. Contrary to the conventional teaching, if the stress on the weak posterior capsule is prevented by avoiding rise in intracapsular pressure, nucleus rotation can safely be done, performed during phacoemulsification in PPC, even those with the congenital posterior capsular dehiscence. Thank you, sir.
Very nice presentation, Dr. Srini. I had a question for you. How difficult was it to rotate the nucleus without doing a hydrodelineation?
It is for those grade 2 and above, it rotates. See, it's what there is in our mind that you can't do phaco without. So, I mean, after it just happened in one case, I just did this. I thought it can be done, and now I'm actually trying it out in normal phacos, like Masuda et al. It rotates. See, initial few cases in the grade 1, I couldn't actually do it. That's there in my this thing, and in those cases, that was initially before I got a hold of it. In those cases, about 10 cases or so, I had to move superiorly because you couldn't get it from there. But once I got used to it, now I'm able to rotate and manage all those cases. See, everyone says, all studies, see all papers, don't rotate, don't rotate. But see, if there is a chance for it to fall down during this thing, it is like the third grading of Dr. Vasavada. It will be spontaneous
And another thing is the epinuclear shell, which we ideally create with a hydrodelineation, would act as a cushioning factor.
Yeah, exactly. That is
because there is no cushioning factor. Don't you think the risk is even higher?
No, that is what I want to see. The hydrodelineation is not a fail-safe one. And hydrodelineation procedure itself is increasing in intracapsular
If
pressure.
you press on the posterior lip initially, I mean not so much, so how much increase in the intracapsular pressure you create is up to you when you are doing the procedure. It's just a thought.
No, yeah, I
It's
understand,
something new.
but there is a possibility. See, why Dr. Vasavada went in for you do a bowl and then do the hydrodelineation was because see there is a chance that fluid might escape and you might have a bit of hydrodissection happening during hydrodelineation. I mean, I know all of you are wonderful phacosurgeons, but in everyone there is a possibility that it might escape. And my point here is that, so I have to have some model to show that it is that intralenticular pressure, intracapsular pressure that we are creating by all these procedures that is causing the very weak posterior capsule to rupture.
What intraocular pressure you maintain while doing phaco in such cases?
Sir?
What pressure you maintain while doing this bottle pressure which you maintain while doing such cases?
So no, I mean, I don't have a Centurion with me. Normally, I do at 106 centimeters on my Signature Pro. So I keep it down to about 95. So that this thing is a bit.
So what we have learned from you, it is something different from the classical teaching. Now tell me one thing. When we do polar cataracts, we are very, very gentle. Whatever procedure we do, hydrodelineation, we try to be most
As
gentle,
gentle as
no?
possible, sir.
So when you are putting a pressure of 95 with your machine, I don't think that your purpose is solved, because in your slide you told that because you are managing it, you are lucky to manage in so many cases, but many times we can land into problems, we can land into mishaps.
So that initial one, it's generally in the anterior chamber, and it's not really located into the this thing. So I mean, I take your point, sir. It is not, the pressure inside is not that great.
You are saying that you are not doing hydro procedures, hydrodelineation, because you are afraid of increasing the pressure. Then again, you are just contrary to that. You are putting a bottle pressure of
No,
95.
without bottle pressure, I can't have a AC there. It's like what normal.
There's one
intraocular
more
pressure.
question. You've done everything fine, but what I want to understand is why did you not do a mechanical separation of the anterior?
So I've tried. See, that is my point. That is my point, sir. You don't require a mechanical separation even. So
No, the question is not whether you
No,
require
that's
or
fine,
not.
that's fine,
It
that's
would
fine.
make your life simpler actually. You are not increasing the pressure in the bag, and also you have reduced the adhesions, so the rotation becomes simpler actually.
Yeah, exactly, sir. See, that is another point in my this thing. Even that is not really required. That is my point. Even that is not required.
Okay, thank you.
Thank you. Thank you.
Ini, thank you. Excellent, but surgeries were excellent. We enjoyed. Thank you.
Just for the rest of the speakers, whether they are present, Dr. Rajendra Prasad, Dr. Richa Chaudhary, Dr. Rajeshri Pandey, and Dr. Pranshu Goel. Okay. Dr. Richa Chaudhary, you can be ready for the next presentation. How many more are present? Three. Yeah. Dr. Neha Shilpi, yeah, please start.
Good morning, judges and delegates. My topic is incidence and risk factors of intraoperative floppy iris syndrome. I have no financial disclosures. Intraoperative floppy iris syndrome is described by the classic triad of billowing of the iris in response to intraocular fluid currents, prolapse of the floppy iris from the main and the side port incisions during phacoemulsification, and progressive pupillary constriction. This poses a surgical challenge and increases the risk of complications during surgery. So, beforehand knowledge of the presence of these risk factors can make the surgeon more careful during surgery. So the purpose of our study was to estimate the incidence and risk factors of intraoperative floppy iris syndrome. This was a retrospective study, and records of patients operated between January to June 2022 were reviewed. This study was conducted at Rio RIMS Ranchi, and ethical clearance was obtained from the Institute Ethics Committee. We included patients who underwent phacoemulsification during the study period, and patients were then divided into IFIS and non-IFIS group. Risk factors such as diabetes, hypertension, and use of alpha blockers were assessed in both the groups. So there was a total of 174 eyes of 158 patients that was included. The average age of the patients was 68.5 years, 83 males and 75 females were included in total, and of them 39 were diabetics and 54 had hypertension. 10 males were on medical treatment for benign prostatic hyperplasia, and of those 7 were on tamsulosin and 3 were on silodosin. Intraoperative floppy iris syndrome was observed in 8 patients. So the incidence that came in our study was 5.06%. For the assessment of risk factors, odds ratio was calculated, and then univariate and multivariate logistic regression analysis was done. In univariate analysis, we found that male gender, hypertension, and tamsulosin intake were found to be significant risk factors, and diabetes and silodosin intake were not found to be significant. Then those factors which came significant on univariate analysis were then subjected to multivariate analysis, and then we found that only hypertension and tamsulosin intake were significant risk factors, and male gender was not significant. That was adjusted when adjusted for the confounders. So in our study, we found that the incidence of intraoperative floppy iris syndrome was 5.06%, which is similar to another study done from India. However, studies from other countries like US, UK, and Japan report a lower incidence, and this can be because tamsulosin is still the most commonly prescribed drug for lower urinary tract symptoms in India. The risk of developing intraoperative floppy iris syndrome on tamsulosin varies from 57 to 100% mentioned in different studies, and it is very less with other non-selective alpha blockers. This can be because alpha-1A is the receptor on which tamsulosin acts, and that is the receptor which is predominantly present on iris dilator muscles. Another thing is there is evidence of decrease in the thickness of the iris dilator muscles with the use of alpha blockers, especially tamsulosin, and eventually there is iris atrophy, which can increase the chance of floppiness. So to conclude, intraoperative floppy iris syndrome has a higher incidence in Indian population. Tamsulosin usage and hypertension are significant risk factors, while the risk is not significant with silodosin usage and diabetes mellitus. A small sample size, however, was a limitation in our study. Thank you.
Good presentation.
Thank you,
It's a
sir.
retrospective study.
Yes, sir.
You could have taken more samples. This is just 6 months.
Yes,
You
sir.
could have taken more samples.
Yes, sir. So this was a study that we did just to find out the initial thing. Now we are
Hello.
planning a prospective study in which we'll have more sample size, and a prospective study will be done so that we don't miss any of the cases of IFIS. Like in retrospective, there is chance of missing if the documentation is not proper. But in prospective, we can look for it prospectively. So this was again our limitation.
Okay. Nee, but was there a need to do a pilot in this?
No, sir, not exactly.
And yeah, any other question? And did you study the incidence in patients who have more than one comorbidity? Because you have separated diabetes, hypertension. There could be patients who have diabetes, hypertension, and
Yes, sir.
tamsulosin.
So that was there. So when multivariate analysis was performed, then all the risk factors were assessed separately. Like in univariate analysis, each factor the risk for each factor was assessed 1 in 1. And then in multivariate analysis,
Was it
other
done?
co-founders were assessed. Yes, sir. Other co-founders were adjusted.
Thank
Find out since when the tamsulosin was used.
Yes, more than 1 month
I
intake
mean, was that
taken
part
as
of
cutoff.
the study?
Yes.
That number of years or the
Yes,
period
yes.
of use of tamsulosin, and was it found that in greater
Longer
than
the
now?
duration, more is the chance.
But
Yes,
that you
we
didn't
found.
mention in your,
Yes, ma'am, that I didn't mention, but that was there, that longer the duration, more was the chance. Since there were only 7
Because
patients
use
in
of tamsulosin causes IFIS, this everybody knows in so
Yes,
many
ma'am,
years.
yes, ma'am.
So what new
Silodosin
has
does-
been added?
Silodosin does not cause, that was an added thing in our study, plus the incidence in our region has not been described in previous
And
studies.
you have calculated incidence in 175 patients.
Doctor, one
That's
thing
a
you
small
told that
population.
you stopped using tamsulosin 1 month prior to the surgery, just now. Do you think this is the right message to send to the house?
No, that stopping
Oh,
tamsulosin does not
When-
decrease the risk of intraoperative floppy iris syndrome.
1 month started or something, she said, not stopped.
Acha, acha.
Pre-
Okay.
Yeah, thank you.
Thank you.
Yeah. Dr. Richa Chaudhary, right? Please start. Dr. Pranshu Goel, please load your presentation.
Very good morning to respected faculty and seniors. My topic is as represented. Cataract is one of the most significant cause of bilateral blindness, and it has come a long way from the era of couching, and now it has evolved as a refractive surgery. Phacoemulsification is one of the most widely performed procedure all around the world, and one of the most common complication is corneal endothelial decompensation. Persistent effort is made all around the world to improve upon the surgical techniques. Our study is a prospective study which compared the corneal endothelial cell morphology and density changes by torsional and longitudinal mode in the patient undergoing cataract surgery. We have also compared the BCVA and the central corneal thickness for both the groups. We have total enrolled 470 patients with immature senile cataract who were aged more than 50 years with grade 2 or more through LOCS 3 grading and an endothelial cell basic count of more than 1500 cells per millimeter square. The individuals were randomly distributed in 2 groups, 235 each, and all surgeries were performed by the same surgeon on Infinity machine. The surgeries were performed using the superior corneal incision and monofocal IOL was implanted. For longitudinal group, the standard ultrasound probe was used, and for the torsional group, the Ozel probe was used. Any complication in the surgery, any previous ocular pathology or pre-op endothelial count less than 1500 was excluded from the study. Our patient had 4 follow-up. First was pre-op, second was post-op day 1, post-op day 7 and post-op day 28. In all the 4 visits, 4 arms were measured. BCVA was measured by the logMAR chart, endothelial cell density, coefficient of variance and central corneal thickness was measured by the specular microscope. I've compiled the result and discussion together, and we are comparing it with the 2 published study, one in DOS and other in IGAO. And the right arm will be our study and the left arm will be the comparative arm. This is our study representing the BCVA, as we see the value of the logMAR going down more in the torsional group, representing a better visual outcome in the torsional group, which was significant with a p-value of less than 0.01. We were in corroboration with the study which was conducted in 2014, where the BCVA difference was again significantly different in the 2 groups. The study in 2018 although did not show that there was significant difference between the 2 groups, but the percentage of patient attaining the BCVA of 20/20 was more in the torsional group as compared to the longitudinal group. When we compare the cell density, our study had the result with a maximum loss which is occurring on day 1 with a minimum betterment over 4 weeks. This was in corroboration with both the studies that we are comparing with, but there was one difference that as we can see it's Shawnee et al., the endothelial cell loss is continuing over the 4 weeks of period, but it sort of has stabilized in our study and the Dasgupta et al. Study. When we compare the coefficient of variance, this was the graph which we got. There was maximum coefficient of variance found on day 1 and which came back to normal by the day 4 weeks. Unfortunately, we couldn't compare this arm with both of the studies. And when we compare the central corneal thickness, this was the graph which we got. There was maximum increase in central corneal thickness on day 1 and there was persistent decrease in it after that. This was again in corroboration with the study of 2018. With this, we conclude that the torsional mode showed better visual outcome as compared to the longitudinal mode. When we compare the torsional mode, we found that there was less endothelial cell loss, less change in coefficient of variance, and lesser increase in central corneal thickness as compared to the longitudinal mode. And this data was significant in all the 4 arms. That will be all, sir. Thank you.
Thank you, Dr. Richa. Did you also measure effective phaco time, phaco duration?
No, sir. That was the one of the limitation of the study, sir. We didn't took the total effective phaco time and the total dissipated energy, sir.
Do you think that's important?
Yes, sir.
Why it was not considered in protocol?
Sir, the sample size was huge initially.
Need to know effective phaco time, what is the sample size relation?
Sir.
Isn't it?
Sir.
See, for all the presenters, you should first have a question in mind for which you should try to look for the answer. You have an answer in mind and try to compare. It doesn't have to corroborate with whatever previous study that has been done. Your study can be unique, no?
Sir.
That's the scientific mind. Just like that, huh?
Sir.
Good presentation, but
Sir.
thank you.
Thank you, sir.
Good morning, everyone. My study is on safety and efficacy of subconjunctival and subtenon block in manual small incision cataract surgery. No financial interest. Among various blocks available for cataract surgery, commonly used are peribulbar, which is the norm for the majority, is blind and invasive and can cause potentially dangerous side effects. Subtenon, which is less invasive but more comfortable to the patient. Third is subconjunctival, which is further less invasive and simpler to administer. It was an interventional randomized control trial having sample size of 196 eyes, 98 in each group, over a period of 18 months in a tertiary healthcare center of central India. Patients with cataract of any grade with no history of ocular pathology and surgery having aged more than 50 years were included in the study. Patients having additional ocular comorbidity, complicated cataract, sensitive to lignocaine, one-eyed patients and deaf and dumb patients were excluded. Pre-operative assessment of best corrected visual acuity, slit lamp examination, intraocular pressure, retinal evaluation, keratometry and A-scan and IOL power collection was done. All the patients were instilled with 0.5% topical proparacaine and 2% lignocaine jelly prior, randomized into two groups, subconjunctival and subtenon. At any point during the surgery, when the surgeon felt that the anesthesia was inadequate, he was allowed to give the intracameral anesthesia. The outcomes measured were subjective assessment of pain on visual pain score analog while giving the block intraoperatively and postoperatively. Other outcomes were eye movements, which was graded into none to slight or moderate to excessive, patient satisfaction, satisfied or not satisfied, doctor satisfaction, satisfied or not satisfied, and intraoperative complications such as subconjunctival hemorrhage and chemosis, and others if any. The study was age and sex matched. The mean age in group 1 was 66 years and the group 2 was 64 years. Majority of the patients were having immature cataract in both the groups. Mean duration of surgery was 10 minutes in group 1 and 9 minutes in group 2, which was statistically insignificant. Mean vision post-operatively was 0.30 on day 1. 100% of the patients experienced no to mild pain in both the groups. 90% patients in group 1 and 93% patients in group 2 experienced no to mild pain during the surgery. Only 10 cases of group 1 and 7 cases in group 2 required additional intracameral block to complete the surgery. Post-operatively, 8 cases in group 1 and 10 cases in group 2 had to be given tablet diclofenac once as there was severe pain post-operatively. Others patient had no complaints. 89% in group 1 and 90% in group 2 patients were satisfied with overall experience of the surgery. In cases, 15% cases of group 1 and 10% of group 2, the doctor was not satisfied due to excessive extraocular movements and not cooperative patients. But in 85% of the group 1 and 90% of the group 2, the doctor was satisfied with the procedure and the block. In all the patients in group 1, moderate to excessive ocular movements were present. In only 11.22% patients of group 2 had moderate to excessive ocular movements, which was statistically significant. Half of the patients did not have subconjunctival hemorrhage and remaining which had mostly grade 1 or 2 and very few had grade 3. 60% of the patients of group 2 had no chemosis compared to 35% in group 1 being statistically significant. Others had grade 1 or 2 in both the groups. Comparing our study, the pain score is comparable with no to mild in all the patients. Considering doctor satisfaction, the study is comparable with 85 to 95% satisfaction of the doctor. Considering ocular movement in both the groups, the results were similar, showing no restriction of ocular movements in subconjunctival group. Most common complications associated with any block being subconjunctival hemorrhage and chemosis were invariably present in all the groups, but did not impose any difficulty while performing the surgery. Subconjunctival block can be employed as a minimally invasive and simple method to administer anesthesia safely for manual small incision cataract surgery. Most patients who undergo manual SICS under subconjunctival block perceive no or mild pain similar to subtenon. Surgeon discomfort is slightly more in subconjunctival but did not prevent successful completion of the surgery. Considering the intraoperative complication, both groups are safe with no major complication. Thank you.
What message? Hello?
Yes, sir.
What message do you want to give to the house with this presentation? Many persons are doing even topical SICS. So what do you want to suggest us to do?
Sir, but still the majority of the surgeons, like in our facility, I'm from GMCH Nagpur, so all my faculties.
Do you think that if you have to operate upon your father or your uncle, will you like to do this procedure? Do you think?
Sir, the study is on SICS, but in that I would go for.
Pain index in such cases.
Yes,
while
sir.
doing SICS in, I think the only skilled surgeons who can perform
Yes, sir.
surgery in a very short span of time
Yes, sir,
can
that-
opt for such sort of anesthesia.
Sir, that is the only limitation because the surgery was performed by only a single surgeon. So this study,
Anyhow.
this conclusion cannot be extrapolated to the beginners or surgeons who are not completing the surgery in a shorter period of time.
Okay, thank you.
What did you learn during the surgery, during the procedure, during the entire course? Like how difficult was that? What were the challenges you had? Because a lot of things were subjective here.
Yes, sir.
So, any challenges you faced?
Sir, during the cataract surgery,
No, not that. During the study.
yes, sir.
See, some studies, they take numbers from the machines.
Yes, sir.
Here, there are no numbers from the machines.
No, sir.
So, what was the learning and what was the challenge? The bias part.
Sir, the operating surgeon, so if at all, like, if the surgeon is skilled and in patients who are being operated under subconjunctival anesthesia, there is no restriction of ocular movements. So if the surgeon is skilled and he is able to perform that surgery under subconjunctival anesthesia,
Did you understand my question?
sir, it will favor it will be biased towards subconjunctival anesthesia if.
Okay, thank you, thank you, thank you.
Thank all the speakers as well as the chairpersons for this session, and we hand over the session to the next panel. Thank you.
And we request the AV team to be ready on time. This morning, almost 20-25 minutes we lost. So tomorrow, you people should be ready on time at 9. We could make up only because 2-3 speakers were not there. Otherwise, we would have run late. Yeah. We go to the next session. Thank you. Thank you.
Yeah. So nahi hai.